so we really hope you'll find this information helpful and help you feel a little more clear and comfortable within your agency of how you can best carry out the oversight and monitoring responsibilities. And we also have lots of resources and tips for playing that role successfully, and we have some great panelists to share those with you. I do also want to mention before I continue, this webinar is being recorded, and so if you have colleagues who are not able to join us today, the webinar will be available both on the NCSW Learn website and also on the FCRP website, and we'll send information out about that to all of you after the event. So here's our agenda for the day. We'll be on together for about 90 minutes, and we'll start out answering the question of why is there so much focus right now on the use of psychotropic medication, because we're hearing a lot about it at the federal level, at the state level, across disciplines, and so we want to talk a little bit about why that is. And in particular, we'll talk about the particular challenges and issues with antipsychotic medications. We'll then spend some time talking about CCNC and want to make sure you have a clear understanding of their role and the ways that CCNC and DSS can partner, because we really feel like there are many ways that they can work together. And so we're excited to share some of that information with you. We'll talk about then the role of DSS and kind of walk through what are some of the things that as a DSS agency you want to be thinking about in your work with families and children. And then we'll talk about some of the other important players that you want to be coordinating with and communicating with. And then we'll have a chance for some Q&A and to get a sense of some of the challenges that have come up for you before we do some closing and housekeeping at the end. Very quickly, most of you have already found this chat box down at the bottom, so just want to remind you that is here. And you can, please do, send us your questions. If you have examples that you want to share or comments on what you're hearing, and if you're having any kind of technical problem, let us know that too. We are going to do our very best to answer all of your questions during the webinar, but I also want to let you know that our presenters have graciously agreed to do a follow-up Q&A document. So if there happen to be questions that don't get answered during the event, we will try to address those after. Okay, so let me introduce our panel for you this morning. Matt Hillman, you know what, I'm sorry, let me just ask, Philip, would you mind logging that in? I think the microphone is on there, so I think that's maybe giving us a little feedback. Sorry about that. You may be hearing a little extra feedback, so we're going to try and get that taken care of for you. So Matt Hillman, I was saying, you can see his smiling face here. Matt is the Supervisor of Therapeutic Foster Care for Catawba County DSS. So I'm going to pause and just let Matt say.
Good morning, everyone.
Thanks, Matt. Glad to have you with us. And Matt is actually in logging on with us from Asheville, so we are glad to have him with us. We also have Kevin Kelley, and Kevin, many of you know, is the Chief of the Child Welfare Section at the NC Division of Social Services, as well as a seasoned webinar presenter from some earlier events. So let me pause and let Kevin.
Good morning, everybody. Glad to have you on. I hope this information is helpful to you, and we look forward to the next steps.
Thanks, Kevin. We also have on with us as I said, two folks from partner agencies, and we're really grateful for their participation. In fact, we have three, so I'm going to introduce them all to you. The first is Jerry McKee, and Jerry is the Associate Director of Behavioral Health Pharmacy Programs for North Carolina Community Care Networks. And we'll talk a lot more about CCNC in just a bit, but let me pause and let Jerry say.
Good morning, everybody. I look forward to talking with you today.
Thanks, Jerry. And finally, we also have, last but not least, Charlene Sampson is a pharmacist with the Outpatient Pharmacy Program at the Division of Medical Assistance. And so let me pause and let Charlene.
Good morning, everyone. I certainly hope everyone gains helpful information from participating in this webinar.
Great. Thank you, Charlene. And we also have Amelia Mahan, who is the Behavioral Health Care Manager Coordinator for CCNC. I'm looking at her to make sure I've said that correctly. And Amelia has just joined us, so I'm just going to turn on her microphone for her so she can also say hello to you.
Thanks. Good morning, everybody.
And we're really glad to have Amelia with us. Because we felt that, and in fact Jerry and Amelia felt that she may be someone that really is a great resource for our county DSS folks when thinking about how to share care coordination for some of the really more complicated situations that you all face. Again, I'm Millicent Blythe. I'm going to be facilitating things today, and I also want to mention we have our excellent technical support from Philip Armfield and John McMahon as usual, and so again, they will be on with us if you have any technical problems. If you chat that you have a technical problem, just one small housekeeping detail, down at the bottom of your screen in the chat box, you'll see a little box light up with either John or Philip's names, and that means they are trying to privately chat with you about your technical problem. So if you do chat about a technical problem, just keep your eyes open for a response from them in your chat box. Okay, so just wanting to make sure we all start out on the same page. What do we mean by psychotropic medications? And you can see here a couple of definitions, those that have an altering effect on perception or behavior, and those that are used to affect psychological functioning, perception, behavior, or mood. You have some great information, as we said, in the handouts that give you more detailed information about psychotropic medications, and some of our guests will be going through those with you during their presentations. But let me just first ask you this question. I'm going to bring up a couple of polling questions. And if you would, go ahead and take these two polls about how comfortable, what's your comfort level now about talking with providers, prescribers, and also with children and youth. I'm going to just pause a few minutes and let folks answer those questions. Okay, so it looks like, I think there's probably still some folks taking the polling questions. So it looks like it's pretty high level of comfort now with talking with prescribers and with families, which is great because as we talk about, that's one of the main goals that we have is to help our frontline DSS folks really feel empowered to do that, and we hope that the information that we give you will make that even better for you.
I'm starting to see the number of responses increase, so please don't be shy. We're using this to help inform our conversation not only on this webinar but moving forward. So please feel free to respond.
Thanks, Kevin. And it looks like the polls are still open, so you can go ahead and select your answer. We'll just leave it open for one more minute. Okay, Great, thank you again. So, yeah, it looks like more than half are feeling pretty comfortable with that role. And again, hopefully with the information you get today and some of the connections we make, you'll feel empowered to do even more of that communication and coordination. So thank you for that. Let me take us back to our PowerPoint. And we also just want to get a sense of what do you hope to learn from this webinar. So before we go any further, we just want to give you a chance, if you would, use your chat box and let us know if you have a particular question or issue that you hope we cover today, and we'll let you know whether or not we're going to be able to. All right, thank you so much, and John is helping us to capture some of these. Okay, so questions about the rules, the medical oversight, basic general information, wanting to know about coordination of care, especially with CCNC and with the MCOs. That's great. This is great. Common side effects, questions about doses. Okay, great. So we are trying to capture your questions, and I think many of these we will cover today. As I said, if there are questions that we're not able to cover, then we will try to capture them in a Q&A document that we'll send out afterwards. Okay, so feel free to keep typing if you've not had a chance to put that in so we can capture your questions for today. And meanwhile, I'm going to turn the mic over to Jerry.
Okay, well, good morning again, everyone. My objective for today is to try to get those that are not optimally comfortable around this topic, around psychoactive medication use in this population, try to improve your comfort level. So, starting at the beginning, an obvious question would be why are we even concerned about these medications? What's the big deal? In other words. So I think very succinctly the issue is, are these medications being overused and under-monitored? This is a question that's taken on national significance, especially in the foster population, but even more broadly in children in general. Leading up to about a year ago, in November of 2011, the Federal Department of Health and Human Services and the Government Accountability Office sent a letter to state Medicaid directors challenging them to take action and to report back to the federal government by June of 2012 a plan of action about what the states would want to do to make sure that in these at-risk populations such as foster children, what is the state doing to monitor and assure that these psychoactive medications are being used both safely as well as appropriately? And further, a number of different medical professional societies have issued guidance statements around the use of these medications in foster populations. But in particular, the American Academy of Child and Adolescent Psychiatry has issued a very nicely worded position statement that's easy to read and understand. But in there they say that foster populations often have biological, psychological, and social risk factors that predispose them to emotional and behavioral health disturbances. And these risk factors can run a whole gamut of different entities, but they lead to, and those risk factors, in addition to the multiple placements that these children often endure, lead to some fragmented care possibly, and oftentimes they tend to accumulate medications over time. So today we'll talk about what we can do to make sure that when these psychoactive medications are used, that they're being used safely and appropriately and for the shortest period of time possible. Now, this next slide is really, I won't go into a lot of detail, but this is really something to get you focused and give you some sort of a program directory to what the different medications, the treatment categories are made up of. You hear these medication names oftentimes, and you may not be 100% sure if this med is an antidepressant or an antipsychotic or a stimulant for ADHD. So this is kind of a roadmap to help guide you. And you can use this as a reference. And further, I'll point out in your handout there are some links to additional information. One in particular that's very helpful, it's been very helpful to me, and I share it with anybody that's interested, is the psychotropic medication utilization parameters for foster children that were developed by the Texas Department of Family and Protective Services, and a good friend and colleague of mine who's also a psychiatric pharmacist, Dr. Lynn Chrisman, has been involved with advocating for foster children nationally. But these are very helpful, and if you're interested in side effects, things to consider, appropriate doses for different populations, this guideline is just replete with that level of detail. So as I mentioned, because of the multiple risk factors that foster children often are encumbered with, they may be at risk for more behavioral health disorders. So in a lot of sense, the medications may in fact be entirely appropriate and indicated. But here in this slide are just some statistics to talk about the prevalence of behavioral health disorders in this population. For example, clinical level behavioral health problems are almost 3 times as common in this population as among the general non-foster Medicaid population. Things like depression, anxiety, social withdrawal, as well as things that are a little more obvious like aggression, oppositional defiant disorder, delinquency. But kids such as those in the foster population, because of their the life experiences, are often you often see these conditions being diagnosed. And just further, due to these risk factors in their past, in part, children in foster care are more likely to have a mental health diagnosis than other children. One study in particular, in late teens, age 14 to 17, 63% of those met criteria for at least one mental health diagnosis at some point in their life. And as I mentioned, these diagnoses ran the gamut from depression, attention deficit hyperactivity disorder, post-traumatic stress disorder, conduct disorders. Bottom line is, these individuals are resource intensive, and the appropriate diagnosis and treatment is paramount to their success in life. And we want to make sure that when these treatments are indicated, that they are carried out in the most expeditious and safe and effective manner possible. And that's just kind of the landscape at a national level. But if we look at the next slide, it shows that and this is North Carolina Medicaid data. Essentially, there's no real difference here in North Carolina. We see the same kinds of situations that we see nationally. For example, foster care recipients in North Carolina are 3 times more likely to have any sort of mental health diagnosis than the general population, and that's about 50% in the foster Medicaid population than 13% in the non-foster Medicaid population. But again, running the gamut of PTSD, depression, bipolar disorder, ADHD, you see the entire spectrum. So please understand, and I'll say this repeatedly throughout the webinar, that psychoactive medications are not inherently bad. In a lot of cases, as you see in the Carolina blue box there, psychotropic medications can in fact be part of a totally appropriate multimodal necessary treatment approach. But again, the higher rates of prescribing this population is what is garnering the attention. And as I mentioned, in an earlier slide that unmet behavioral health needs and mental health needs can actually be an impediment to the child's success both now and later on in life. Because of the long-term problems, it might impede their psychosocial growth and development, obtaining appropriate education to make them successful later in life. I will point out, though, in having said that psychoactive medications can be an appropriate part of treatment, seldom are psychoactive medications alone an effective long-term strategy. Trauma-based therapy is increasingly being used in this population because of the risk factors, as I've already alluded to. And actually, well, I'll talk about this in a later slide. So advancing to more concerns, I just want to emphasize on this slide that there is data to suggest that some foster children, especially those in rural areas, may actually be prescribed psychoactive medications at a lower rate than you would expect because of limited access to care. So especially in North Carolina, which is largely a rural state with some few larger metropolitan areas, but largely in the west and the east, we have large rural areas. Access to care is a barrier sometimes to appropriate care. And I'll just one last point about this slide is medications should always be prescribed only after a comprehensive clinical assessment has been performed. So if you're not seeing those kinds of baseline physical and behavioral health assessments being done, and a medication is just being prescribed up front, then that might be one of those things that would cause a red flag to be raised. And I'll further point out in the Texas guidelines that I mentioned earlier, there's a nice one-page summary of a number of different things that you might be that might raise a red flag. Not to say that they're necessarily and inherently inappropriate, but I think if you see any of these situations on the red flag list, it might cause you as a caseworker to ask further questions and get more information to make sure that what's being done is in fact in the best interest of the child and the family. So I've already talked about the comprehensive clinical assessment being done. Seldom, I mean, there are cases where in an emergency, a medication would be the first step if a child has suddenly become aggressive, or they have a psychotic break, which would be very rare, but it could happen. And the child is of imminent danger to themselves or others, then that may be the first thing you see done. But again, that would not be something that was done in isolation without other supports being added in a long-term, more multimodal treatment plan. Let's talk a little bit about just a few definitions, in particular polypharmacy and off-label. Polypharmacy can mean a couple of different things. It can mean more than one drug in the same medication class being used at the same time, like 2 antipsychotics, or it can also mean psychoactive meds from different medication classes being used simultaneously, like 1 antipsychotic, 1 antidepressant, 1 mood stabilizing anti-epileptic drug. So you have to be careful when you hear that term to know exactly what is being meant by it. What does happen is pretty clear in this population, as well as the adult population. There's absolutely no clinical evidence in large-scale clinical trials to suggest that multiple medications in the same class are more effective than any single dose, any single medication where the dose has actually been maximized. What you do see happen when multiple drugs in the same class are used is you actually increase the risk for adverse effects and unintended consequences to occur. The other issue I wanted to touch on just very briefly is off-label. Now, around the child and adolescent population, you hear the term off-label use being tossed around. What that actually means is, especially in children under 18, many medications, and certainly the psychoactive medications, have not been as well studied in this younger population than in the adult populations. As a result of that, lack of good long-term clinical study and evaluation, a lot of these medications do not have FDA-approved indications for the use of these medications in the younger population. So what happens is providers use their experience and the clinical data from adults and try to extrapolate that to young children, and that may not always be the best practice, but just simply because these medications have not been studied well in the younger population. It's not exactly clear what the long-term implications of using these medications in children might be. The last thing I'll touch on is the use of these medications in the very young. For example, kids less than 3 years old, there is the only clinical evidence in this very young population are just a few case reports that have been published. So it's if you see these medications being used in a child less than 3, that would certainly raise a flag that you may want to ask some very pointed questions of the provider and the caregiver support team when you run into something like that. As I had alluded to earlier in talking about how the foster children may be recipients of kind of fragmented care because they may go from one placement to the other, that is the nexus of a concerted effort between the state and county level DSS workers, and as well as Community Care of North Carolina, to get these foster children enrolled in a primary care medical home environment where that the primary care medical home coordinates and acts essentially as a quarterback for the healthcare services that this team receives. So all the care is delivered through that primary care medical home. We've seen in community care's experience with other populations that typically the quality of care improves and the cost of care actually drops as the quality improves, in that there are less crises, and it's really promoting wellness, appropriate immunizations, well checks, and that kind of thing. So it really sets up the patient for long-term success. I'll just jump back one quick minute and look at some of the psychoactive medication use statistics in the North Carolina DSS custody population. At any given point, there's somewhere between 8,000 and 9,000 children in this DSS custody, and that's about 1% of the overall Medicaid population in that age group. And so we're approaching 10% receiving at least one antipsychotic agent, compared to 2% in the non-foster Medicaid population in the same age cohort. So somewhere around 5 times the magnitude of exposure in the foster versus non-foster. Reading further down the slide, the thing that really jumps out to me is the next to the last bullet. Almost 25% had a prescription for at least one psychoactive medication. And then some approaching 6.5% had at least 2 psychoactive meds, and we had some with 3 during a 12-month exposure period. And then further, as I mentioned, the young kids being exposed, 3.6% of the kids in this foster DSS custody population, 5 or less, were exposed to at least one medication, and certainly as the population ages, that exposure rate increases. I wanted to talk just a minute before I turn it over to Charlene Sampson from DMA about in particular, some specific health concerns around antipsychotic medications. These are, if you refer back to your table of medications, the antipsychotics are the things like Abilify, Seroquel, Risperdal, Invega. in the adult population, but increasingly in the child population, we're seeing that there's a well-established relationship between the prolonged exposure to these medications and the development of what we refer to in healthcare as metabolic abnormalities. Metabolic abnormalities include a host of problems such as weight gain, blood glucose abnormalities, meaning elevated blood sugar, developing lipid abnormalities, meaning your cholesterol might be elevated. These problems in very young children would set that child up for perhaps a lifetime of problems that would certainly impede their quality, if not both quality and quantity of life. So we want to avoid inducing the metabolic syndrome in these children. One way to do that is through effective monitoring, but we see from the literature that that's not being done very consistently on a national basis. This 3-state study that the results are up here on this slide, a study that was done in Medicaid population, in child and adolescent population in Missouri, California, and Oregon for a period of a year, and we saw that the blood glucose was only being followed, and these are kids that were having at least one prescription for an antipsychotic. The blood glucose was only being checked about a third of the time, and lipids were only being checked about 13% of the time. Fortunately, in North Carolina, due to a program that Charlene will describe to you, we've seen those rates, which started out not much better than this. We've seen those rates of safety monitoring improve to about double what these numbers are here over a period of 2 years. So at this point, I will turn it over to Charlene to talk about what North Carolina did to begin to make this possible.
Thank you, Jerry. And I'm actually just going to jump in before we turn it to Charlene. Let me just ask folks if you have any questions to go ahead and type them. There was one quick question I'm going to ask Jerry or Charlene. I think Intuniv is something that we're seeing prescribed a lot more. Can you just say what category of drug Intuniv is?
It's none of the above. It's called alpha adrenergic agonist. It's used typically as an adjunctive therapy in children with ADHD who still have anger and aggression, and it kind of helps them manage those sort of outbursts. But thus far, none of the stuff we've talked about in terms of antipsychotics necessarily applies to Intuniv, other than oftentimes you'll see kind of an interesting concoction of psychoactive medications that will include Intuniv.
Thank you. And this question will probably get answered a little bit later, but I just wanted to ask Charlene and Jerry if you would say anything initially, the question of how do you convince or talk to a medical provider that a child does not need to be on psychiatric medications? Are there particular things you might recommend a DSS worker focus on?
Yeah, we'll actually cover that in a little more detail in some subsequent slides, if we can just hold that.
Okay, that's fine. And Jerry, I'm going to ask, once Charlene starts, can you just type in the chat box the category of drug that you said that was? I think that Intuniv is. I think folks are trying to get that. Okay, let me pass to.
Good morning. This is Charlene Sampson. I'm with the Division of Medical Assistance Outpatient Pharmacy Program. The next several slides are about the policy Medicaid put in place to address the high use of antipsychotics, in particular in the child and adolescent population. In April of 2011, the Division of Medical Assistance implemented the policy Off-Label Antipsychotic Safety Monitoring in Beneficiaries through age 17. Now, this policy is widely known as A+KIDS, which I hope is something that sounds very familiar. A+KIDS is an acronym for antipsychotics, keeping it documented for safety. The policy addresses the widespread use of antipsychotics off-label, and Jerry spoke earlier about what off-label is. But I'm also going to share with you how the policy defines off-label use. It's defined in 3 ways. First, the antipsychotic is prescribed for a diagnosis that has not been approved by the FDA. Secondly, the antipsychotic is prescribed at a dose amount outside of the dosing range established for an indication, meaning the prescribed dose amount either exceeds or is less than the FDA-approved amount. More often, we see the dose amount exceeds the upper limit. And lastly, the prescribed antipsychotic will result in the concurrent use of 2 or more antipsychotics or antipsychotic polypharmacy. And polypharmacy is something that Jerry addressed earlier as well. The A+KIDS policy is really a prescriber initiative. The policy requires the prescriber to submit information when prescribing an antipsychotic to any Medicaid or health choice beneficiary aged 0 through 17. The A+KIDS registry is the web-based program created for prescribers to submit the required documentation. Now, the kind of documentation requested includes, it's pretty basic. It includes the name of the antipsychotic, the dose, the length of time on the medication, and then we also get information about the monitoring of recommended parameters such as glucose levels, body mass index, and lipids. These parameters are indicators for side effects that could result from the prescribed antipsychotic. Now, this data is collected to help ensure at least annual monitoring is done because, as Jerry alluded to, there is the use of psychotropics in general are just under-monitored in the adolescent and child population. Appropriate monitoring is essential to establish baselines and to measure change as therapy continues with these drugs. It's important to mention here that the policy does not restrict antipsychotic medication choices, so the full arsenal of these antipsychotics are available for prescribing to Medicaid and health choice beneficiaries. And the policy does not limit how these drugs are used. So the primary purpose of the policy is to promote safe use of antipsychotic agents when prescribed off-label. So who is involved? The policy applies to all Medicaid and health choice beneficiaries through age 17, and certainly the foster care population, the foster care children are in that population. All prescribers of an antipsychotic for these children must submit the required information when prescribing an antipsychotic. So here is the real-life application of the policy. Any prescription for a new or refill supply of an antipsychotic medication requires the safety documentation. If the information is not provided, the pharmacy claim for the medication will not process successfully. Now, this could result in a delay in getting the medication. Medicaid has incorporated multiple measures like prescriber alerts, pharmacy override opportunities, daily reporting about claims that don't process successfully to help keep delays from happening and ensure beneficiaries are able to obtain medication timely. This next slide lists resources that are important for a DSS worker to know since they may need to direct prescribers to the policy, the web-based A+KIDS registry, or the fax form, which is also an option to submit information. In the event there is a delay in obtaining an antipsychotic medication or questions about A+KIDS arise, these are first-line resources for help. So certainly keep this slide or familiarize yourself with this information so you know where to turn to get confident and reliable information around the policy. Now, this is a screenshot of the Document for Safety website. As you see, A+KIDS is the first program listed. You are encouraged to visit the website. Click on the link where it says to learn more about A+KIDS. The resource tab has a printable fax form that can be used to submit information. The policy is found there. Articles about evidence-based use of antipsychotics. There's a frequently asked question tabs. There's just a wealth of information accessible on this website. Anyone can log on to www.document for safety. Only a prescriber should launch the A+KIDS registry where actual safety documentation information is submitted. To access that application, provider registration is required. Page 5 of the handouts, I will mention, has the A+KIDS form, so certainly look over that to see the type of information that is captured, which also closely resembles what is submitted through the online web-based A+KIDS tool.
And Charlene, let me just direct a few questions to you, if I could, specifically about the A+KIDS. Jerry, I know you have some data you're going to do, but one question from a DSS is, how do you, what happens when you have a psychiatrist or prescriber who refuses to participate in A+KIDS?
Certainly, we collaborate with CCNC and Jerry in particular around this occurrence. As I said, we are closely monitoring our antipsychotic prescriptions, and we get reporting that indicates, gives us information about those providers who are not submitting the information, and they are targeted primarily for education to help engage them in this policy.
That's great, thank you. And another question, if there are any similar reporting policies for private insurance that you're aware
of? I'm not aware offhand. Jerry, you may know of some.
There are some other state Medicaid groups that are using right now paper-based systems similar to our web-based registry. In particular, the state of Maryland has a very aggressive safety monitoring program. Private insurance has went the way of more step therapy and just simply not allowing these antipsychotics to be used, certainly in populations less than 3 and sometimes less than 5 years old, because the FDA approved indications for 2 of these antipsychotic medications don't start until the age of 5, and those are very narrow indications for irritability associated with autism. So that's kind of the pathway that the private insurance has taken.
Okay, thank you. And Jerry, do you want to?
I will, and just to take what Charlene was saying about the CCNC collaboration around providers who were not interested in participating. We do have across the, and we'll talk about this in a little more detail later, but across the state there are 14 different CCNC networks. Each of the networks has a network psychiatrist that we use those network psychiatrists as well as the network pharmacists as appropriate to reach out to these providers and try to educate them around the importance of doing what they're doing for the safety monitoring. So it's a process, but our participation has been up in the 80 percentile, and that continues to improve every month. Just wanted to share before we move forward away from the A+KIDS registry some of the initial output information from the registry. There, as of August, late August of this past year, there were over 1,200 prescribers who had at least one child with one authorization in the registry, and then that amounted to almost 30,000 authorizations, because you may have multiple authorizations for the same patient, because the registry requires that the provider touch base periodically with the registry and update us as to the status of the child. But this involved around 15,000 total patients. I will say that this registry was designed and continues to be supported going forward with an advisory panel consisting of Charlene, myself, and some others. But we do have representatives from the 4 schools of psychiatry across the state: UNC, Duke, East Carolina, and Wake Forest, as well as community care. So we do have broad-based multidisciplinary representation to give this more of a reality orientation. And as Charlene mentioned, there are ongoing efforts to reach out and to providers and encourage them to help protect these children by providing this safety monitoring. We think that the best step is going to be and we've already sent out some aggregate data, but starting in early spring, we will be able to send out to the specific provider their performance information regarding the children that they have in the registry compared to the aggregate data. And nothing motivates individuals, myself included, like a scorecard. So we really think that's going to be a good positive step to even further engaging the audience. So we're kind of at a transition point here. I don't know if you wanted to stop a second, Millicent.
Let me just see, Jerry. I'm looking. I think that most of the questions are more about coordination and communication. So I think let's keep going, and we'll address those as.
Okay, so now we're going to start talking just a bit about community care and how it works. Community care was formerly known as Carolina Access 2. But as I mentioned earlier, we're in the business of connecting patients with the primary care medical home as a healthcare delivery system. And we're growing fairly dynamic. The number of people that we touch now is up to 1.27 million individuals all across the state. We're up to about 5,500 local primary care docs now. And we believe that these individuals are well connected and have resources to better manage the Medicaid population, just because of their links to community providers. Every network, as I mentioned, we've got a map coming up next slide. Every network across the state has a care team to help coordinate care. We have nurse care managers. We have behavioral health care managers that Amelia Mahan will talk a little bit about later. We have a whole host of network PharmDs, psychiatrists, and medical physician directors to keep that care connected and moving forward. And we're going to try to demonstrate to you why it might be important to know who these people are in your network. This is how the state is carved up, just for your information, for the various networks. As I mentioned, just in terms of how the network is made up, each network has a physician, a medical director, or a clinical director who's typically a well-known physician in that community, and by virtue of being a kind of a stalwart in the community, they already have connections built in to help make their job easier in terms of connectedness to care. And this network clinical director helps to provide oversight for quality improvement within the practices, the primary care medical home practices in that network. And it's all a matter of promoting evidence-based care and trying to shrink the gap between the actual care and what we know as best practice evidence. So it's an ongoing piece of work, and in particular in the behavioral health realm, the behavioral health integration team has only been in place for about 2.5 years, so that's truly a work in progress. But in particular, just as I've mentioned on the previous slide, nurse care managers to help coordinate more medical care services, but also to some extent behavioral health services. We have behavioral health care managers whose real focus is on behavioral health care coordination, and then the network pharmacists can assist with care coordination around medication use and adherence, and medication reconciliation and review. The psychiatrist is, of course, a real valued clinical resource around behavioral health integration and the importance of that. And of course, we go to these individuals when we're reaching out to their peer psychiatrists within those networks to try to help get them on board with evidence-based practices. One thing I did want to say, and I mentioned this earlier, or alluded to it earlier, that there's been a concerted effort in the last 18 months between DSS and CCNC and North Carolina Medicaid to get these foster children enrolled in the primary care medical home. Again, because of the multitude of risk factors and the fragmentation of care, the consensus was the primary care medical home might be a really great solution to some of these issues that the foster population was encountering. and I won't read you this slide, but there's within this slide it shows that the cost differential between the non-connected foster population and those that were in community care was fairly substantial, and we believe that going forward, as we get an increasing cohort of these children enrolled, that again not only will their overall care coordination and quality of care improve, but that cost savings will follow. So I wanted to now turn it over to Amelia to talk about the care management process.
Sure, thanks, Jerry. So yeah, CCNC, we do, as Jerry alluded to, we do have many, many nurse care managers spread across our different networks. And as a whole, CCNC has mainly been focused around medical needs. And so that is where our nurse care managers are highly skilled in working with folks with pretty intensive medical needs, with the focus being on making sure that patients are getting the right care at the right point in time. Patients or individuals come to our attention in lots of different ways. One is through a series of pretty significant reports that we have that look at identifying individuals who are maybe not just the highest cost and highest need, but they're individuals who are outside the norm of other peers sort of with similar kinds of conditions. And so that is, those are a lot of the folks that our care managers focus on. Okay, sorry, hopefully you all can hear me better now. So one way that we identify folks for care management are through these reports that we run pretty regularly, identifying folks coming out of the hospitals who need transitional care, who need specifically med reconciliations done as they're coming out of the hospitals to make sure that we can try to prevent them from going back in. Care managers also receive referrals through primary care practices. Many of the care managers are embedded in these primary care practices and work really closely with the practice and with the care team in the practice, and so there's a great benefit to the practice when they have those care managers there. But I think this is where it's going to be critical as DSS workers, as you identify kids who have these needs, particularly needs that are comorbid, so there's a medical need and a behavioral health need. This is where our care managers can really step in and be very effective. We don't take the place of the LME MCO, which is the specialty behavioral health system. So as you identify kids who need specific psychiatric needs, specific really intensive behavioral health services, our folks can help make those linkages, but we don't replace the LME MCO and getting them connected to that. But that is basically how we do care management. Can I go on to the next slide? Okay, I'm sorry. So the question is raised here, and I think it's a good one, is if, as a DSS worker, if you are working with a child who has complicated, again, medical behavioral health needs, and who would benefit or you think might benefit from care management, the first step is to get them enrolled in a CCNC primary care home. Like Jerry said, it used to be called Carolina Access 2. Some people still refer to it that way. Get them connected that way, and then those referrals can be made directly for care management. You can go through the primary care practice for that. You can also go to the network directly, and I believe in your handouts you have a list of the different behavioral health coordinators in each of our networks. As with any list like this, I always want to stress that it's subject to change. People leave, people move positions, so what is a correct phone number now could change. But that is a great starting point. If you have not met your local CCNC network folks, the behavioral health coordinator is a good inroad into that. You can make referrals that way. Also, just contacting the network directly, and they can look at it and certainly can assist. And if they are not able to provide care management, can hopefully point you in the right direction. Okay. So back to you, Jerry.
Okay, so we'll talk about network pharmacists. One thing I wanted to point out that I haven't already said, because as I mentioned, all the networks have at least one. And these individuals, similar to what Amelia was mentioning, monitor data. We're oftentimes looking at population level kinds of information, but on a patient level, as these individuals transition from one care setting to another, these pharmacists are involved in medication reconciliation, up to and including medication, full-blown comprehensive medication review. Their efforts in interacting with providers around these medications to simplify complex medical regimens, removing duplicate therapy, medications that are questionable in terms of do they continue to be needed long term. And I want to mention something too that at this juncture that state level DSS and community care has been involved in a pilot project in the 9-county project broadcast areas where if a child was taken into emergency custody, oftentimes they're taken into custody and the medical and medication information as well as the medications are left behind, and the DSS caseworker is kind of at a loss as to know what to do, because they just don't have that history, or they're clear what to do in terms of connecting with a provider, but they're not sure about the level of urgency. So we initiated this pilot so that they could the county level within these county level caseworker within these 9 counties could send a fax to or in the pilot they sent the fax to the central office, and I did the evaluation, essentially looking at the criticality of need for getting the child quick access to care. For example, we were concerned about children who were being treated for asthma, diabetes, if they might have a seizure disorder, if they had a bee sting allergy and needed support for that, cystic fibrosis, those kinds of things where you didn't want them to have a significant gap in therapy. Myself and soon we will roll this out statewide. The pharmacist will make an evaluation and send an evaluation and a referral form back to the fax this back. This is all through a secure fax network. Fax it back to the county level DSS worker along with information out of the provider portal, which is basically a profiled, easy to read set of information that is in our informatics system at CCNC based on claims data. It gives medical visits, hospital visits, ED visits, as well as medication information. So without belaboring that, so that look forward to an announcement very soon about this program being rolled out statewide. We think that it will be a nice augmentation to what you're currently doing as far as providing information to you. And now it's back to Amelia for this last slide.
Sure, and as I said already, each network has a behavioral health coordinator. I'd encourage you to focus on those folks as being your point of contact, and their role is really to support the primary care providers in dealing with behavioral health issues that can be dealt with there, and to help those folks know how to connect to specialists. So I think that should be your main, hopefully a good point of contact in making contact with the network.
Okay, then the last piece of information, I've already mentioned this, the patient profiles that are information that's derived from claims that are in our informatics center. There's some information in your handout that shows you what this would look like. And as Amelia mentioned, you need to get to know, meet your behavioral health coordinator. They can give you the local network-based informatics administrator who can be your conduit for accessing this information on a case-by-case basis. Our aspiration is long-term to get the county level DSS folks access to the provider portal where these patient profiles are housed. But meanwhile, while we're working on that, you can get this information through the network administrators. So again, I think we're ready to transition to Kevin.
Here to the literal definition of the law and learning a lot more and coordinating with DMA about best practices. So again, if this is a shift for you, that's okay. Part of our mantra is we're continuously improving, and this is one of those areas where we think some improvement needs to happen. at the local level and at the state level. So we're all learning and growing and trying to do better.
Kevin, and I want to say, I know Kevin has had some communication with the Child Welfare Attorney Generals, and so we do know this is a shift, and so we will also provide a follow-up Q&A document that will clarify some of this in writing as much as we know at this point, and as Kevin said, some things will need to be clarified as we go down the road. I just want to mention, Lucinda Wilson mentions that they automatically request courts to give authorization for medical consents to DSS. I didn't know if you wanted to comment on.
It would help to unmute my mic. Okay. I think you'd have to take a look at particularly the medication that the child is on. I don't think a blanket authorization to treat the child as deemed necessary kind of language would suffice, but if that's where you're going with it, doesn't mean that you have done something terribly wrong. It just means that we recognize that a refinement in the policies and procedures need to happen. One of the other questions that I saw was around medication disposal, and I know that's a concern for the Child Fatality Task Force, because we do see accidental ingestion of medications, kids looking for a high, if you will, and sometimes non-accidental completely, just taking the wrong medication. So many communities have started to do regular medication roundups, I think was one terminology for them, and I would ask you to contact various entities in your community with public health or other entities about conducting a medication roundup, because proper disposal of the medications is very, very important. You've probably seen various media reports about, please don't dump it in the toilet, that starts to pollute our water system, but yet we certainly don't want it left in the medicine cabinet. Again, the Child Fatality Task Force is paying attention to that, and hopefully you'll be able to access at some point a method to properly dispose of medications that are no longer needed for one reason or another.
I'll just interject here, Kevin. That was a good answer, but increasingly in communities at the local police department, local sheriff's office, there are medication disposal drop boxes where you can just drop by 24/7 and dispose of any unwanted medications. If you're not clear about any of this, the medication take back days, or whether or not your local police department, sheriff's department has a drop box, ask the pharmacist where you got the medication. They can help you, route your disposal appropriately.
Thank you, Jerry, and I do recognize, one, to pay nod, that even the Child Fatality Task Force recognizes that there's not an answer that's going to work in rural communities. Certainly, the pharmacist may not be able to provide an answer for you, but just keep persistently asking around, and the more you ask and the more you identify that as a need, the more likely it is that the community can respond. I think law enforcement and pharmaceutical community would be a good places to start, but like I said, public health I know is also concerned about this.
Kevin, thank you all. I know people are continuing to chat in some really good questions about the consent issue, so I'm going to say we will work with the division and with the Attorney General's office to get written answers to some of those, but I do want to move on to some of the other big issues that have come up. One of them has been advocating with doctors, and we're going to get to that in a minute, but this first one is working with birth parents, because we know that sometimes birth parents do have a lot of concerns and issues about psychotropic medications in particular, and so I'm going to ask you all if you could let us know some of your challenges and also some of your successes in helping bring parents on board around the use of psychotropic medications. And while you do that, I'm going to turn to Matt, who has been waiting patiently in Asheville. And Matt, if you would tell a little bit about, from your experiences in Catawba County, some of the things you've done to keep.
Can you guys hear me now? Okay. Yeah, we at Catawba County, are really striving to try to keep parents involved with in our treatment team meetings, also working with having them in there with the psychiatrist. I think one thing that we're looking at is also trying to look at the amount of kids that come in under medication compared to the amount of kids that enter care without medications that we add medications to, and trying to see what cases we are adding medications in, so that we can, look at our practice and try to see what we can do there to inform those parents better why we're going to ask for maybe psychotropic medications or a psychiatric assessment on that child.
And I know there are some other ideas coming in, including parents in conference calls and medication management meetings. I think, this may be a change in practice for some agencies and certainly with some families to try to have birth parents there with those conversations with medical providers so they can hear some of the information directly, because I know how challenging it can be to feel like you're trying to relay information to a parent. And so I'm actually going to want to talk a little bit about that role of coordinating between parents and physicians, prescribers, and all.
Thanks, Millicent. And I think the first bullet says an awful lot. It's okay to ask questions. You are in many ways acting on behalf of that child and that family to be informed as you can about the medication, and then to spread that information. I think a lot of times parents don't want the children on medication, in part because they don't fully understand the benefit from it. There are obviously, of course, risks and side effects that we want to watch out for. But at the same time looking for alternative treatments to address those underlying issues may give that parent the reassurance that they need to approve that medication, and then to continue to engage them in the conversation around monitoring of that particular child, their child, in terms of the response to that medication. I think if it's the proper medication, then you're going to see some benefits from the child receiving that. And when you can share that with the parents, you're going to go a long way. And I know it's sometimes tough, and sometimes you run into prescribers and physicians who, are probably very overstressed in terms of their time frame, and they want to continue and get the next appointment moving along, but as that sort of surrogate for the child and family, that's your time and your opportunity to ask questions that may be relevant to that, and I think being part of the CCNC network is really going to be a benefit, and you can always engage them when you have a particular provider that for one reason or another isn't getting you the answers that you need. Don't be afraid to reach out to their network provider and talk to them about your experiences with that particular provider, and they may give you some tips on engaging them, or maybe it's time to look at a different provider. A second opinion is never a bad thing. So I think that's important, and then a role that a social worker can play, hopefully be more informed and to share that information. So we've proposed a list of questions. These certainly aren't, checklist items. We don't want you to try to, answer all 9 or make sure you ask all 9 every minute, but look at them before the appointment and to see what, or the communication, it doesn't necessarily have to be the appointment, and to see which ones are most relevant and which ones that seem to be particularly poignant, either for the parents' needs to feel comfortable, or maybe the treatment team, the child family team, has questions about a particular aspect of psychotropic medication for a particular child. I think these speak for themselves in a lot of other ways, and now use them as warranted.
Say something. You go on to that one. I just wanted to mention these questions. I think this addresses some of the questions that came in earlier about when you are working with a treatment provider who you feel is not really engaging with you in a communication about why there are psychotropic medications being given, especially why are there antipsychotic medications being given, that these types of specific questions hopefully can be helpful. And also to just reiterate what Amelia and Jerry said, that the CCNC also, because they have network pharmacists, that their pharmacists are available to work with DSS to look at a child's medication regimen and help sort of give some suggestions about coordinating that child's care. And I'm sorry, because we are so short on time, I'm going to just flip through these last few slides, if that's okay, Kevin. We did get some specific questions in the beginning, folks wanting to know, specifically about side effects on medications that the children they work with are prescribed. And I think, while we certainly don't have time to go through individual medications, I think the bigger message is to use CCNC as a resource and those medical home providers to make sure that the children and their caregivers do get answers to those questions, because the role of DSS is not to be an expert on every medication or really on any of these medications, but simply to make sure that the children and their caregivers are getting their questions answered.
Sure, thank you, Melissa. I appreciate that, and I do now recognize how close we are to time. I just want to real quickly speak to Aaron's and Pam's question about doctors, providers who become upset and defensive, I think is the word we often see when that, and Jerry and other folks are paying particular attention to that. So obviously we can't control a particular provider's behavior, but we recognize that's the issue and that we need to add that to our list of the statewide message out to the network providers. Well, yeah, just the next slide, real briefly, I think it's real important that we engage those private agency staff regardless of the placement setting. A majority of our children in many areas are now placed with private agencies, and don't forget to include their staff in the conversation. They have a tremendous role in ensuring that the best care is provided and the children maximize their well-being. So we have a good public-private partnership in the provider foster care world, both family and congregate care. So I didn't want to skip over and make sure I say a word about engaging those private providers. So again, our DSS critical role, as Millicent said, you don't have to be an expert in this, fortunately, because certainly we would be challenged to do all that. But I think the mantra of advocate, educate, and communicate is a good way to frame it, and you can always say, look, I'm just trying to ask questions here. I'm the social worker. I need to know all this information because I'm being held to a standard to ensure that this child's long-term well-being is enhanced. And I think that may help to diffuse it, and again, to be the nosy person when sometimes parents and children can't speak for themselves. And hopefully the medical home and the CCNC networks are going to come along with us, and I know they are going to improve the system and to reach out to all of the providers across the state so that we hear this coherent message. There's a number of initiatives underway to enhance the medical homes with particular emphasis on children in foster care. So I think you're going to see some vast improvements in this area as we move along.
Thank you, Kevin, and thank you. I also want to mention that Jerry reiterated some of the great resources that they've provided in your handouts, in particular on page 3, the National Alliance on Mental Illness and those Texas Red Flags, some really great web resources for when you do have particular questions about a particular medication, side effects, what to look for, etc. Great, and written in language that's also helpful for youth and caregivers as well. You do have our presenter contact information in your handouts. I want to say a huge thank you to Kevin, Jerry, Charlene, Matt, and Amelia for being with us, and we had a few little technical problems, and so thank you all for being patient.